very few of us having much sleep ahead of the impending lockdown. Possibly the person sleeping the least during this unprecedented time is Minister of Health, Dr. Zweli Mkhize, and he joins us now in the main to allay some of our fears and, of course, to answer some of your questions, because a lot of clarity is, of course, sought by so many South Africans at this point. Minister, thanks so much for coming through.
Thank you. Good morning to you.
Nice to see you, Minister. Thank you. We're used to speaking on a telephone, but it's now good to have you here in studio with our social distancing in place.
Yeah, we've got to keep our distance.
Exactly. I mean, Minister, it's been a very tough time for not only you, for all South Africans, a very, very busy time. This is, we're not even into the full of it, are we? I mean, we're in for a tough ride ahead of us.
Very far from it. We are expecting that there's still going to be quite an increase in the numbers of cases, and we also expect that a lot of work has to be done by South Africans to contain this infection. We're still on very early days. Right now, we have actually increased from yesterday. We're now at 709 cases.
Wow.
The largest increases would be Gauteng at 64 overnight. Then Western Cape 61 overnight. KwaZulu-Natal 11. Free State 15. I think we must also watch that those numbers are increasing. Now there's a huge difference in what is happening if you look at the pattern. Free State is the one that we should be concerned, because it's all around Mangaung area, and this emanates from an incidence of a church which had 4 travelers, with 5 would come from abroad, US, UK, Israel. They were part of a church experience. And in the process, before they left, they developed symptoms after interacting with about 300 or 300 people. And this, we've actually been busy with the contacts, and we've issued a call that all those who are part of that church must actually contact the Free State government and be tested as contacts. A number of them who we are finding there are actually contacts who emanate from that particular church conference. It was a 4-day, about 4 or 5 day thing from the 9th to the 14th. And that has actually given us a number. It's already creating what we could call an epicenter, which means that you have one area which has got a very high concentration of infected individuals who are turning positive. So this is an issue that we need to focus on. The team are doing very well in the Free State. We've been reinforced by Red Cross, and so we've traced a number of contacts. It's really coming to quite a number, because at this point, the first few people, the first 300, need to be rounded up, and as soon as each one of them becomes positive, then we have to now go to their family contacts, their workmates, and all of that. So that net is widening, and we have to deal with it. The other areas are very scattered cases, with the largest number being around Johannesburg. And I think here you are still seeing quite some of the urban centers, such as Sentin area, around that, where you've got a larger number of people. And the Eguruleni, Tshwane, is a bit less there. And then in the Western Cape, largely around Cape Town, and that's where you're seeing a number of cases as well. So the approach that we are taking is that we need to look at the major source still has been the contact with the countries that we have identified in Europe, which is the global epicenter. So that's really how it's moving now.
I imagine, Sakina, I know you're going to come in, but I just wanted to ask this question, which a lot of people have been asking, and we really are going to spend this interview asking you questions from viewers, because they don't have direct access to you.
Sure.
But a lot of people now with this lockdown are traveling to their homes. They're going back to the villages, they're going back to their home provinces before this lockdown. Who knows what they're taking with them? And is this a big concern for you? Because we talk about the fact that this originated from these high-risk countries, but now we've all, in a way, been in touch with everybody. I mean, that's just the way socialization works. Is this a concern now?
It is a concern. Let me just, if I could just take you through how we're hoping to contain the virus. Firstly, we have identified the travel history as being a major issue. Those European countries, we can count them all. We've actually got people coming from all of them. that basically are South Africans who are returning from a holiday abroad, or travelers who are coming into South Africa for a holiday. Now that lot, we have said that those who are found to be positive, we have actually put them on isolation, so they are not going to infect anybody. So those are fine and safe. Then the next lot are those who would have come from those countries but are not aware that they might be posing a risk of infection. That means both the returning South Africans as well as tourists who are coming to the country. So now we're encouraging that we must restrict the movement of everyone, just to be able to get everyone to settle down so that we don't continue the spread. So it will be spread into hotels, it will be spread into workplaces, domestic services and so on. So we need to therefore restrict the movement of aeroplanes and cruise ships, because that's where we need to really watch at this point, which means we now want to encourage people, instead of coming straight into the country, they should be putting themselves into quarantine if they come from these countries, until we've got 14 days where the virus will either show itself or it will burn itself out. And so that is the very important second area that we're looking at. The third area is to go inside the country. Those who have been tested positive must give us a list of the people that they've interacted with. Those we call direct contacts. Now that is where you will find the workmates, the employees, the friends, the people that you meet in the bar and so on, in the church and so on. So those now we need to actually trace them. So we're calling for anyone who's been in contact to be able to give us the names of the people that they were with, so that we can talk to them, test them, and then observe them and put them into quarantine. If that lot is actually now put in quarantine, that's a third area which is now reducing the spread of the infection. Then one thing remains. That is internal transmission, where people don't know they've got the infection, but they already caught it. That's where the traveling becomes an issue. The lockdown is supposed to address that aspect. The aspect that means that we must avoid large movement of people. And we're very grateful that the churches have cancelled the Good Friday, because that's where a huge mixing would have happened. That has saved the country enormously, and people will never know to what extent that contribution has actually saved the country from spreading of infection. The next issue, therefore, that becomes a challenge is large movement during the Easters, like in holidays where thousands of people move from one province to the other. We want to discourage that. We want people to stay put where they are, so that when we look for contacts, we must find them in the addresses that they are supposed to be in, so that those who might have been exposed should be in the same location for the duration of the 3 weeks, during which we expect that the virus will either show itself or will burn itself out, because it takes about 14 days for the body to actually shed the virus up to converting to negative. That is what we need. It means, therefore, that when we talk about lockdown, it's not about the movement of cars and working and so on. It's the mixing of people that we want to limit. In this case, when you reduce movement, the lockdown will stop the trains, will stop the taxis, and that way a mixing of people who could have been having infection is reduced, so that for the duration of the 3 weeks, fewer people will get infected. We must be able to pick that up as we test people. If we don't pick it up, it means people have locked down, but they've gone into their homes, they're continuing to infect each other. That's the biggest risk that we must actually talk to South Africans about.
The one thing that comes up as well, and I don't know if you feel this, is the provincial, you're talking to people not to travel home during this lockdown period. Won't the provincial borders be closed? I mean, if you can enlighten us on that. I mean, if I am in Gauteng, surely I'm not allowed to even consider driving to KwaZulu-Natal during that lockdown period. Surely the borders will be controlled between the provinces and all of those things. Or is that not happening?
Well, I don't want to make any specifications about it, because the Defence Force is going to be deploying, and so we'll see how they manage that. But the issue is that we don't expect a lot of traffic, mainly the service, particularly essential services and the logistics, because we still expect that some of the transport should be used for people who are going to hospitals, those who are sick, those who are buying food, as well as transport for food and people who are in the health, medicine, supply, value chain, and so on. So those who are dealing with essential services, you can't completely close the borders because of that. Now, the question of reducing the numbers, we're going to really make an attempt at reducing the numbers of people who have to go out into the various places, into the various provinces. But we do want to discourage people from, again, making huge migration of people, because it's those numbers that are of concern to us. But what is helpful is that when you stop the taxis and you stop the trains, that means that the numbers of people who are traveling is going to be less, and so the mixing is going to be reduced. But the restriction is going to be put on the roads, so that we try and allow only the people who are supporting the essential services should be on the road.
Minister, talking about the testing aspect of it and the challenges you face in this regard, firstly, the number of test kits that are available to do the tests on people who want to get tested. What is the backlog in that regard, first and foremost? And secondly, with regard to the figures that are released on a daily basis, how accurate are they in terms of the actual number of infected cases in the country? Are you able to gauge at this point?
You will never know that you have tested everyone that needs to be tested for various reasons. One, we do have a constraint. Right now, we have done more than 12,000 tests. That's a lot of tests to be done. They were talking to us about Korea, which did over 20,000 tests, and they were talking about when they started. Now, 12,000 tests is not a small number. It's a good start, I think, where we're starting. But what we are seeing is the constraints in terms of availability of reagents, and also trying to decentralize testing and increasing the numbers of equipment. We are increasing that. So over a period, we expect that we should be able to make available testing much more localized at district level, so that several centers in a district should be able to do that. But that will take a while, because there are certain constraints that you have to accept now. That when we have the flights interrupted, it does interrupt the flow of reagents that we need, and so we have to make additional alternative mechanism to deal with that. But we believe that we'll overcome that problem, and we believe that by next week we'll have improved quite significantly our testing capability. So that's the one issue. The other aspect is that there was a case definition, which meant you test those who come and present with a travel history and symptoms, or a history of contact. Now, at the beginning, that was very helpful, because that's how we've got most of these people that we've got. Now we're beginning to see internal transmission. Now, this requires us to change the approach. So we've got a ministerial advisory committee of clinicians, epidemiologists, pathologists, virologists, all of those who are now dealing with the whole management of this virus, who are now looking at refining the definition as to who we test. It's going to be important now to shift. We have to shift now to firstly saying, apart from those who have got a history of travel, we need to actually go for contacts and people who are in the vulnerable areas. Now, vulnerable areas would be areas where there would have been people located who have been tested positive, that we must now check the communities around that. We must also look at our health workers who are exposed. We've had a number of health workers now who were concerned that they would have been exposed. One of them in Free State, we're not sure whether it was a history of travel or that it was to do with the patient that the health worker was affected. We do know that about 3 doctors that are affected have actually been traveling, so we think that they have imported it from somewhere else. So the most serious aspect for us is not to expose our health workers to the risk, and so it's important for us to be able to test those if there's a need, so that we are able to make sure they are protected. And then, of course, in most of the countries, people who come with chest symptoms are very, very vulnerable, and so we need to be able to test as many of those. Now, as the clinicians were indicating, in one case, just if you took one situation, let's say pneumonia, we estimate that in the whole country, you'll have probably 1,000-2,000 people who are admitted with pneumonia alone. But if you wanted to add coughs and sore throat and fever, that number blows up significantly. So there has to be a combination of testing with clinical assessment, so that the doctor must have an indication that this one could be at risk, and therefore with a higher index of suspicion, you are able to get the doctor to direct as to who needs to be tested and so on. If you went by who wanted to be tested, it would be very difficult. Right now, again, what is making a bit of a difference is that most of the people who are exposed are those who have got means, who have been traveling abroad, and so they can pay for it. So 10,000 of the tests that have been done through private laboratories, which means that people could afford. It does become a challenge, because once you've tested once, then your problem is, why do you pay another 1,400 again when you're feeling better? And yet we need those results. So we need to up our capacity so that we can test everyone, to be able to give them an exit test that says, no, now we know for a fact we are no longer infective. So it's a balance of all of these issues that we're working on.
So when you give us the updates on the positive cases every day, you see an exponential increase. Why is that? Is there a backlog or is there a time delay with regard to the release of those results from the laboratories, from the NICD, and how big is that particular challenge at this point?
We have reduced it quite a bit. As we speak now, our figures would have been the latest from either 2000 or 2300, between 8 o'clock and 11 o'clock, depending on how the team has dealt with it. Certainly after 8 o'clock, sometimes it might be 11, depending on how long the team was working. So I would say safely these numbers will represent anything that was tested before 8 o'clock last night. So the delay is actually shortened. We wanted just to make sure that we don't have a very long lag before we can actually announce the numbers. So that is one issue. The second issue is that you're going to an area which really is a bit of quite a quagmire, if one may say. Firstly, the numbers of people who test is numbers who go to the doctors to test. So depending on how fast the laboratories can test them and how much their reagents can be are available. So you might have variations there. So one day, if there's a shortage of reagents, there would be a delay, and then they would be put in the next batch as soon as the reagents are available. After the president had issued the call on last Sunday, we saw a surge in the numbers of people who came to test. That actually helped a lot, and that's why you saw suddenly the numbers going up. So to what extent the increase is driven by increasing the numbers of people who are testing is something that we're busy discussing here in terms of how to evaluate. We still have a need for us to go out and test people who we suspect and may not necessarily have had a travel history. So we want to increase that side. So once we increase those, we believe that the numbers will increase, numbers of positive will increase, because we have already started seeing contact becoming positive. The case of the Free State is exactly one case. First we had 5 people, and then the next time we rounded up all the contacts, we got 15, and then of course again we got another 15. We are close to 30 right now. So that number indicates that there's quite a lot of local spread. In this case, it's unique because there was a high concentration of a very close contact with 5 people who were infected, and everyone was not suspecting. So that will expect in any case that the numbers are still going to go up. Now, what we need to do is to go beyond the line and stop the line from increasing by actually quarantining everybody so that they don't stretch the line further. But now, once we start opening up to more centers, we expect that the numbers also may still increase. But at a certain point, the base should stabilize, and therefore we'll now be able to say from now on we're testing an unchanging base of community. So whatever we're showing is a reflection of what is happening on the ground. Right now, there's a variation, so but still the numbers are increasing, and the tendency is changing from imported now to be internal transmission. That's why when we say there's a lockdown, we basically are saying freeze everybody so that we can test and just check to what extent we have and to what extent can we actually separate those from
Minister,
the public.
We need to take a break, but before and as we go into this break, people may have missed it in the first hour. You have announced now that there are 709 cases. What we need to find out from you, and if you could elaborate a little bit for us, critical cases in South Africa, Do we have any? And so far, are we still on 0 fatalities?
And if I can just add to that, Minister, we've seen in countries like Spain and Italy, physicians on the front line are being particularly affected. You mentioned that. Have any of our clinicians tested positive?
Okay, firstly, 709 new cases, no fatalities. We've had tests turning negative on the first 5 of the people, 4 in KwaZulu-Natal, 1 in Gauteng. But in addition, all of the patients are improving. There are only 2 who are in ICU in private hospitals. And so all of them are basically improving. We're just waiting for the test to be done. So we would say that side, things are pretty much stable.
Let's take a break here on the program. Our conversation continues with the Minister of Health here. We've got a lot of questions coming through. We turn our attention to them after this. Stay tuned.